You've heard from Dr. Healy. You've heard from Dr. Antonuccio. Kim was referenced in Dr. Healy's presentation. Kim is a drug advocate and she's actually a member of the FDA advisory committee and has helped establish black box warnings on medications. That'll be our panel. We've got questions and it'll be run by our two moderators. Our first moderator wanted me to introduce him as Faraz Merchant, mediocre psychiatrist. I refused to do that. And I decided I would introduce him as Faraz Marchant, slightly above average psychiatrist with an even better personality. And then the moderator, most of you don't need to be introduced to him. He's your professor. He's taught you every class you've had at UNR, Dr. Dean Hinnitz. So we're off to the races. Thanks, everybody.
Yeah. So first of all, thanks for staying. I know that everybody's leaning into a meteor shower of data, and this is our time to sort of cohere, pull it together, and sort of paint a picture out of it. The question that I got, and this would really be for anybody, we get a lot of questions, and this one captures it. What about drugs for things that people consider more heavy duty, like schizophrenia or intense bipolar? Any of the research or medications that come out for those? Do you have an awareness of that?
What about the other thing? Can we use this?
Yeah.
You want, okay. It's, you've seen that it was fixed by the woman here. The antipsychotics are even more likely to cause you to commit suicide than the SSRIs. The Risperdal, Zyprexa have got the highest rates of completed suicide and suicide lacks in clinical trial history, but you're not told about this. Schizophrenia is not an illness that causes people to commit suicide. If you look at the data from the United States back through to the 1950s when chlorpromazine was introduced, there was almost no one committing suicide who actually had schizophrenia. The rate of suicide went up after that. But it's not just the so-called psychotropic drugs. Antibiotics like doxycycline for acne can cause you to commit suicide. It's a serotonin reuptake inhibitor. Prozac is a serotonin reuptake inhibitor. That's an antibiotic. It can kill off your gut fauna, and it causes people to commit suicide. Lots of antibiotics can cause problems. Altogether, there's a risk.org website that I'm involved in, and we've identified 500 different drugs that can potentially cause you to commit suicide or homicide. Anything that can cause you to commit suicide can cause you to commit homicide.
Yeah, I was going to say, you heard that I'm on the FDA Psychopharmacologic Drugs Advisory Committee. So as the consumer rep, so I represent the public. So I see a lot of drugs that are coming to market, and I know we said 2 clinical trials, but a lot of the drugs that are coming to market now that are being reviewed by the FDA are being used by like fast tracking mechanisms. So they even have clinical trials. And the one that we just saw that I just completed my last term. So, but it was the combination of SSRI, of Zoloft with Rexulti. And it's and what they're trying to do is get these things approved for, the schizophrenic, but using it for add-on or for depression or for PTSD. So I think the reality is we're just seeing a lot of different medications being used. And they do have the trial data isn't necessarily there. So.
Okay, I'm going to keep our answers short so we can get more questions. So what they said, good enough. Let's go to the next question.
No, that's okay. So much. This is a really good question. And I think the answer can be answered by Dr. Healy, but how can research data be suppressed ethically? Like, how can this be allowed?
Company trials are not research. they're assays to get a license. And they're a commercial exercise. And one of the interesting things with informed consent forms, the very first informed consent forms were devised by a man called Louis Lasagne, aiming at telling you you're about to take a drug that is not currently on the market. And you are being informed that there is this risk. In the 1962 regulations, he played a big part in the shaping of the regulations and got informed consent built into company trials. And industry looked at this and said, oh, that's a good idea. And the lawyers added a few words in to tell you that when you sign this form, quite apart from you being told this drug isn't on the market yet, you were told that, we're going to show your data to no one. And that sounds great to you. Absolutely, they're going to keep things private and confidential. By no one, they mean not even FDA. FDA do not get to see the data from company trials. The data is you. Your name is important. Your name needs to be there on the documents from the trial, so that a doctor like FDA can get in touch with you and try and work out what happened. Let me explain quickly to you. Let's put it this way to you. 25 years ago, I had a lady come into me, and I can still see her in my mind's eye. She had red hair, and she's wearing a green cardigan, and she said, look, I'm not able to make love on Celexa. I said, I know this happens, but once you stop it, you'll be fine. Even for a weekend, if you want to go away for a romantic weekend, things will be fine. And she looked at me and said, I've been off this drug for 3 months. And I can take a hard, bristled brush and rub it up and down my genitals and feel nothing. Now, if FDA had doctors who interview you, but they don't, and if they were to get in touch with her and interview her and heard that, there's no condition in medicine that produces a situation like this. But the drugs she was taking can do it when she's on them, and now that she's off them, it's clear as night and day that the drug has caused the problem. But to this day, 25 years later, FDA are resisting warning you that your ability to make love might be wiped out by these drugs. And it comes down to the lack of an interview, person to person. The companies used to interview you. You get in touch with the companies and report a problem happening to you, and their doctor would talk to you and would often conclude, our drug has caused the problem. But then they were told by their lawyers, we're arguing in court, that randomized control trials are the only way to show a drug causes the problem. And we can't let you, the doctor, just on the basis of interviewing one anecdote, decide that our drug is causing the problem, so you can't do it. So when you report to companies now, they pass the reports on to FDA, knowing FDA don't have a doctor who can interview you, but giving you, it's all part of building up the impression FDA are responsible for determining cause and effect. We and the companies don't know how to do these things. Doctors don't know how to do these things. The experts in FDA who are there because they don't like doing clinical work. They don't like meeting people. They've rarely met a person, and that's why they're in FDA, and we're leaving them to be the ones to decide that the drug is causing the problem or not, and they resist doing it.
Let me just make one comment about the suppression of data. We saw the study done by Dr. Turner. There's no law that requires them to publish the results of the study. So that file drawer problem is real, and it distorts the literature in a way that makes us think things are more effective than they really are.
And I was just going to say, we've got lawyers in and that is one way to see how the trials have been actually, the games that the companies play. And that is one of the things that I was able to, through my work, is seeing what happens through litigation. And I think litigation is a part of really getting to the bottom of what you saw on some of the slides here.
One more quick point on that is we had all hoped to have a lawyer here called Skip Murgatroyd, who is taking a legal action against the journal that published study 329. This is at the Paxil case where they looked at a clinical trial of children who were depressed. And I think those of us who know Skip and have seen what he's doing figure he's likely to win it, and this study will be retracted. The issue for us is how to make you all aware that the New England Journal of Medicine is no better, and JAMA is no better, and company studies in these journals are not evidence-based medicine. They're hearsay. If you cannot bring a person into court to be interviewed, which you can't, bring any of the people who are in a company trial into court to be interviewed in front of a jury for you to weigh what they're saying, then you don't have evidence.
All right, thank you. Our next question is really, it's personal and it's clinical. Person writes that they're currently on an antidepressant, Zoloft, and have been battling with the emotional bluntness that comes with that, considering going off of the drug, but in so doing has a rise of anxiety and anxiety attacks. And the drug suppresses these anxiety attacks. And so the question is, where do you determine there's a worthy trade-off? And any advice, very clinical question, any advice about coming off these drugs, the resumption of the symptomatology, and what's the balance in terms of person's decision-making?
Yeah, you got. These are very difficult decisions. People have a right to pursue that goal if they want. They need to find resources to help them understand the best way to come up. You know, sometimes that's a physician prescriber. Sometimes it's somebody like Brooke Soon, who has made herself an expert in this area. Her book, There May Be Side Effects, explains the challenges. But it has to be done carefully, and you need to find someone, probably a prescriber, who is supportive of that effort. I don't recommend that someone just stop any kind of drug. That's my opinion.
I was just going to say, I know we have a couple people in the room, and I feel like there's something about the real world experiences. And, you know, there are groups out there, and there's a lot of support groups as well. And so I think there is, it's probably in conjunction with a prescriber, but also the real world experiences are very important as well.
One of the highest periods where people are likely to commit suicide, there's a twofold thing. One, when you go on the drug, it's a bit like at the space shuttle. The risks are when you're going out into space, when you go on the drug, and when you're coming back to Earth, when you're withdrawing. There's a very high rate of suicide during that period. So this is not a risk-free period. And no one really knows how to reliably help you. If you don't, it's not so much getting an expert. There's a bunch of experts who have their theories about how to help you, and that can be dangerous. You want someone who's going to listen to you and work closely with you, and try and support. I mean, it's about trying to support your sense of what's right for you. But you need to bear in mind that some of these things can't be helped. You may have damage that's not easily reversible, or I had a psychiatrist friend who came off the drugs. He was quite keen to come off. It took a year to come off. And he said, yeah, I'm better. I'm pleased I'm off. Things aren't as good as I hoped they were going to be. And then 5 years later, I got an email from him saying, what do you know? Things have come back to normal. So it can take that long.
Sorry, I have to say something because I am actually a psychiatrist in the community.
Above average.
Just barely above average, right? The thing is, Dr. Healy, I very much respect what you're saying. And one of my questions later on was going to be like, okay, there are all these very serious effects of being on these medications. How can I, as a community psychiatrist, in like a limited time visit, properly give the information to somebody in a way that's digestible to them, that doesn't actually spook them? Because like the types of side effects you're talking about are extremely scary, but and real. Let me just say that, but not common. And as but the majority of people don't experience every single side effect that you're talking about.
50% hold their SSRI within a month.
Say it again. I didn't hear you. Say it.
50% hold their SSRI within a month. Up to 20% drop out of the clinical trial, which is only a 6-week trial, because of serious adverse effects.
Sure. Okay.
And they've given these drugs to healthy volunteers, and within a 2-week period, they've committed suicide, or during the withdrawal period, they've committed suicide. And you can't blame the illness for this. This is a drug effect. So a short form of informed consent.
Sorry, you're saying that the majority of people have committed suicide?
No, I said in healthy volunteers,
Uh-huh.
you've got people who've committed suicide, either going on the drug or coming off it. They don't have a mental illness. They've just been there as healthy volunteers. These are trials that the companies have to do before they bring the drug on the market. There's no clinical confidentiality here. None of these people have a mental illness of any sort. There's no reason why the data shouldn't be published, but it's not published.
So you're saying,
This is why you don't know about it.
50% of the patients will have side effects, not that 50% will become suicidal.
Oh, no, not 50% becoming, but they will have serious problems enough, like an inability to make love. The single commonest thing an SSRI does is to numb your genitals. 95% of people, you're saying these things are rare, 95% of people will have numb genitals to some extent. Some will have profoundly numb genitals. And that can proceed to, you'll also get loss of orgasm, loss of libido. That happens generally on these drugs. It's much more common than the benefit. The reason a mood effect is called the benefit is the companies plan to benefit from making money out of selling it for that indication. They're not figuring that this is the thing that's going to happen most often to you, and that's why it's called a benefit.
Okay. The thing I wanted to address was the original question about how to safely come off of these medications. I have very safely taken many people off of medications. I have regularly engaged in deprescribing. The type of effects that you're describing, like for example, post SSRI sexual dysfunction, which is something that you have seen in your practice. I actually had never seen a case of it, not one. And I was trying during your lecture to actually find some sort of prevalence rate. It's not studied well enough to even produce a prevalence rate that I am aware of, but maybe you can enlighten me.
I have a published article on the problems of this, which I'd be happy to email to you.
Sure. But you don't know prevalence rate for
The particular problems, trying to find them, it's the kind of thing that until recently, people who've got PSSD, a bit like AIDS during the 1980s, haven't wanted to let anyone know that they have this problem. So they don't tell a doctor they have the problem.
Mm-hmm.
A lot of doctors, when you come along and say, I'm unable to make love, I've got numb genitals, and I know a few people this has happened to, they don't believe the patient. They ridicule the patient and they say, you're crazy, we're going to detain you in hospital and start you on an antipsychotic. That happens. So in situations like this, it's very difficult to find an incidence rate or a prevalence rate.
There was a study done by Tejo, I believe, in Spain, with, 1,000 patients, and the prevalence rate was 60% of the patients had some sort of sexual side effect.
Yeah, there's at least.
But I was talking about post SSRI.
Yes, this is
sexual
post.
dysfunction.
No,
That's separate. There's
no.
the
Same
same established for that.
No, the same group have looked at a large number of people who are on SSRIs and how things were after they've stopped. And up to 50% did not return to normal. I don't know whether this is full-blown PSSD, but they did not get back to baseline.
Your contention is that up to 50% of people after they get off of an SSRI don't have full restoration of
This is a particularly big study that has been published. I don't know that I believe it or not. I'm just telling you that's a study that's out there if you want to have a look at it and see what you think.
Okay. That makes total sense to me. And for the record, right, like I have definitely seen patients experience sexual dysfunction on these types of medications, but like you said, the point of your talk is to get doctors to listen to patients. The point of what you're trying to do, Kim, is to get doctors to listen to patients when they come with any sort of side effect. And I think what I want to say is that, like, to add some balance, that me, along with pretty much every psychiatrist that I associate with here in town, are the type of people that do listen, to their patients. The portrayal that you're making of psychiatrists not listening, I am 100% certain is real, because I got to finish. I 100% certain is real. But at the same time, right, like there are actually good psychiatrists that do listen. Yeah.
There are great doctors. The problem we've got is good doctors who are following the standards of care and following the drug label, and who haven't, when you come in and talk about something that's not on the label, they figure you're fantasizing. The way companies have played the game, it means doctors don't put you ahead of a label the company has written, which FDA has looked over and said, fine.
Take this. I was going to say, like, on the PSSD, like, I know that there's been citizen petitions at the FDA that they're waiting to get the FDA to put it on the label. And so I think there's been lawsuits that were brought forward from public citizen. And I think at the end of the day, it's the FDA, and it's why I keep saying it. I know I'm a broken record with, we are not anecdotes. I'm not an anecdote, but I think this idea, there is something to be said about the real world experience and what I've seen, even on my role at sitting at the FDA in the beginning, at the beginning stage of the new drugs that are about to come on the market, because they're controlled by the industry. And so I always say, of course, they're gonna always put the best foot forward. It's not the level set of the real conversation. And so I'm always concerned what's happening in the real world when millions of people start taking it. And so that's where.
Yep. Let me give you what I think is an amusing story. We created a petition about PSSD, which we sent to FDA and we sent to the European Medicines Agency, EMA.
For the audience, you probably should say what PSSD is.
Post-SSRI sexual dysfunction. That is, you stop the drug, you're expecting things to come back to normal, they can get worse, and they can remain that way for the rest of your life. And I know roughly 30 people who've committed suicide because of it. It's not something that people like to live with. You're often also emotionally numbed pretty profoundly. But okay, so we figured this should be the label of the drug. We got in touch with FDA, we got in touch with the EMA, and I wrote, knowing that FDA don't have doctors who are going to interview any of you, and knowing EMA don't have doctors who are going to interview any of you, I wrote to a bunch of people who have PSSD and didn't want anyone to know their name, and said, look, we need your name. It's about people. We need to be able to give FDA and EMA names so that they can get in touch with you, your contact detail, your email. You can't decide cause and effect on the basis of RCTs. You've got to decide it on the basis of an individual case. It's like a man murdering his wife. So FDA didn't want the material. We got 80 people to write a report on what had happened to them, and we got half the doctors, almost 40 doctors, to write as well, saying, I've been treating this patient. I'm not saying the drug has caused it, but I can't see any other reason that it's happened. And we had all this material and offered it to FDA, who didn't want it. We offered it to EMA, and this is where the amusing bit happens. And they said, oh, yeah, sure, fine. I happened to know the boss of EMA, which may have made a difference. He said, fine, yes. And I got in touch a week or two later, and this will appeal to you. I got in touch a week or two later and said, did you get all the material? I mean, it was a big heap of material. And he said, yes, we did. And we followed protocol when it came in and removed all names.
Yeah, that's absurd, right? Like, obviously, like, individual, like, for extremely serious side effects like that, it makes total sense to follow up on individual anecdotes for sure. And, sorry, cases, I apologize. Individual cases, right? I didn't mean to be insulting in any way. Like that makes total sense, but what you're saying is extremely relevant to me as a psychiatrist in that like that information is not getting filtered down to the clinical level to me so that I can properly advise people. So what I'm asking is I'm in a room, right? We've come to the conclusion that perhaps we have to use an SSRI, right? Perhaps, okay? Theoretically. What kind of spiel am I giving? How would I properly give informed consent
The
to?
very simple spiel
Yeah.
is, I'm about to give you a poison, and I need to remember that's what I'm doing, and you need to know that's what's happening, and we both need to keep an eye out on whether you're being poisoned or not. That's the simple spiel at the start.
You want me to say it like that?
Well, you said you wanted something simple.
Yeah, I'm just clarifying. That's how you would like me to say it. Yeah.
The important thing here is you can't really give much more detail because FDA don't have the detail from company trials. They haven't got it. They haven't seen it. Okay. So nobody knows what these drugs can do. They cause visual problems that aren't in the label. They cause sexual problems that aren't in the label. Thousands of people have these problems and they're not in the label. The key thing isn't informed consent before you. I mean, that's important, and they need to know that you're the kind of person that recognizes things can go wrong. The key moment is when they come back to you and things have gone wrong. And the question really, if it was me coming back to you and you weren't, you might be looking at me, you might be listening to me, but also looking and listening to the label. My question will be, why do you not believe me? And you guys need a doctor who will put you first, who will believe you unless they've got a very good reason. Mental health. There's always going to be some patients who are trying to game the system. But we shouldn't be acting as though every patient is trying to game the system. Medicine won't work. For the most part, if people come back to you with a problem, they've got a problem. They've got an incentive to make things up. And if we're not believing them, there's something gone wrong with medicine and with us.
Besides poison, like a medicine with benefits or risks, something like that.
No, I think things have got, look, life expectancy in the United States is full. You're down around 80th in the world. You're way behind everyone else. The reproductive replacement rate is disastrous. Not quite as bad as Korea and things like that. Disability rates are ridiculous and escalating among young people for mental health reasons. You've got to be blunt. We've gone past the point of pussyfooting around it.
Okay.
We get a turn?
Yeah.
So as a psychologist who's getting patients, clients coming in, many on antidepressants, they can get a release to talk to their doctor about what's going on. I have some other thoughts, as my students know, I might have some other thoughts about how to treat. But I'm going to talk to somebody who spent 12 years of their life studying everything that you're dismantling here. If someone called me and said, we just found out listening is bad for you, I'd be staring into a meteor shower in terms of my own thoughts about options. How am I going to talk to a physician? I feel easy with Dr. Faraz about, I have a whole nother point of view about what's going on here. And I don't think neurotransmitter problems are the problem. What's the discussion that you have with a physician, especially if they saw that doctor before they saw this doctor?
Dr. Fully grasp question. David.
Well,
What I've been asking.
you're asking what you tell.
I have some thoughts about different kinds of depression. As you said, whether it's a depression where somebody's parent died, whether they realize they're going to die, whether they took 21 credits and are buried, the kinds of depression we're talking about are as multivariate as could be. But someone comes in, they're already on medication. I'm going to get a release to talk to that doctor about what you talked about. There's some other things going on here. People have been dying for decades now. This person's suffering from that. they're overwhelmed, whatever lack of relationship things might be going on.
Yeah.
But I'm going to talk to a physician who's going to tell me there's an imbalance in their serotonin or dopamine or whatever it is. It's a tough conversation. They've been trained for 12 years to look at this perspective.
One aside, that's why I stopped doing that, because I wanted the patient to pursue it if that's what they're interested in doing. I didn't find it useful. This is just me to talk to another doctor about such a thing. Now, maybe other people do find that useful, but
Okay, let me reverse things a bit and then add something else in. I left a bit out of the talk. I talked about, low serotonin idea and the chemical imbalance being a biobabble. It's kind of meaningless.
It may be biobabble, but they have 12 years of training.
Sure. No, but let me push it back to you and see how you'd respond to this one.
Yeah.
The recovered memory stuff was bad. Legal actions put an end to it. We've now got trauma-informed care. We've got complex PTSD, which essentially are psychobabble slogans. There's not much meaning. I mean, everybody knows roughly what we're talking about. We're talking about, hey, you've got some kind of biological reason or some kind of psychological problem. But these words get floated about and they're used widely by psychologists as our badge of identity. Now, that's what doctors are doing as well. They like to have an idea about our drug fixing something. It's mistaken. But let me turn around and tell you, I think the problem is a little bit more like this. I'm thinking of a young guy who comes in, he's at school, he's been bullied a little bit, but not much. It's the kind of stuff we've all had when we were at school at some point or other. And he comes in with his mum, and she's a nice woman. He's a nice guy, and he has, all his friends have told him that, the SSRIs have made a big difference to his life, cleared his thoughts, and they're much happier, and he wants one. So I say, well, look, they can cause problems, these drugs. And I say to him, look, you're a bit young yet, but pretty soon you might begin to lose your hair. And young men, when they lose their hair a little bit, get very worried. They don't like the idea of going bald. And they can take a drug called Propecia, which can restore your hair, but it can cause you to commit suicide. And it can wipe out your ability to make love for the rest of your life. Would you take the risk? And he said, no, instantly. I said, if you had a few acne spots, and, there are things we can do for acne other than give you Accutane, but dermatologists rush into giving this drug, which is used for cancer chemotherapy, but it's now been used for a few spots of acne. And it can wipe out your ability to make love for the rest of your life and, of course, you commit suicide. Would you take it? He said, no. I said, well, it's a bit the same with the SSRIs, okay? And he paused and said, yeah. And I said, look, go home and think about it and things like that, and we can meet again in a week's time. But I knew we wouldn't be meeting in a week's time because his mother was taking an SSRI. And it's a bit like smoking. If you come from a family where one or both parents smoke, the kid's going to smoke, probably. If you come from a family where they don't smoke, there's a much less likelihood the kid is going to smoke. We've got a problem at the moment. So many people are on these drugs that it's not just you talking to the patient as such. It's not just me talking to the patient. It's you're the family circle and the friends and everyone else. And there's no easy way for you as a professional or me to put things right on our own. It's a culture issue.
So what does my conversation with that doctor look like, given the information from this conference?
Yeah, well, I think the one thing I have found gets doctors to listen is if you say to them, if these drugs work as well as you think and are as free of problems as you think, you're going out of business. That's the one thing they listen to.
So therapists should tell the doctors that they're going out of business if it's working as well.
Well, it's not working for them. No, I thought it was you talking to the. You talking to the doctor. Well, okay, if it's actually the patient, then yes. I had hoped the conversation here was going to be us listening to you guys here, rather than you listening to me in particular or us. There's a lot of younger people these days going along to doctors with a range of different conditions, with a concealed video camera, and recording things for a minute or two, saying, look, I have this problem, and the doctor's saying to them, you're crazy, you're deluded. And when they put these things on TikTok, they are making doctors look terribly bad. And I think it may need guerrilla action like that to make a difference.
The reason people aren't talking because they submitted their questions ahead of time, so I'm gonna read one for you, if that works. Okay. This one's from an audience member that says, do you think depression along with other mental disorders are over or underdiagnosed in today's society?
Can I?
Take a guess what the answer is gonna be.
I do. I think, the reality is, and I said it earlier on a podcast, that we need to go, we just automatically go as consumers even, like, I'm feeling sad, like right after my husband died, I went to the doctor, or the doctor said, do you think you need something? And I'm like, well, I think the drug is what killed him. And I go, but more importantly, aren't I supposed to hurt? Aren't I supposed to hurt? My husband died. And she literally, this was my doctor, said, but you don't need to. And that was what she said. And I think that is a very real, I hear this all the time from people, that this idea that we're hurting. And I think there's a lot of people out there. Life is happening. And I think there's this quick fix pill mentality. I think the culture is such. I think, when I hear like friends' kids that are on it and they're like thinking it's a bragging thing, they're on their Alexa homes and stuff like this. There's a cultural thing that's happening as well. And I see some people nodding. So you probably have heard this as well, right? Like, I think there's this idea that we're not supposed to hurt and we're supposed to feel, but we are. Like, that is what the human experience is. And I think we need to go back to having an understanding that as humans, life is not supposed to, it's like a heartbeat. The heart, if we had an EKG, there's ups and downs, and then there's a little bit up and down, and then that up is going to last, and then it's going to come back down. But if it's flat, which is what a lot of these drugs help to do, that means you're dead. And so I feel like as a culture, we need to push back and maybe not give our power away necessarily. And no offense to all the medical professions, but we go and I feel like we forgot what it's like to be human. And I know that we have this. We have this problem where there's a lot of people who want to get off of them and they're having problems getting off of them. But when they do, they feel life. And so anyways, I just feel, so thank you for letting me chime in on that.
And regarding whether they're overdiagnosed or underdiagnosed, I'm pretty sure that, and correct me if I'm wrong, is that most antidepressants are prescribed by non-psychiatrists. So most of these people have not had a thorough interview, diagnostic evaluation before they're prescribed. So they may not even meet criteria for some kind of depression.
And let me just say one more thing, because it's one of my favorite things. The PHQ-9 form, which is what a lot of GPs use, and it's also the form that at every one of our doctors' offices, whether it's a pediatrician, the GP, your gynecologist, it's part of the paperwork that you fill out at the time when you are looking at your insurance forms. And it's like, in the last 2 weeks, have you felt sad? Have you felt, all the questions? But nobody, like when I pointed it out to the doctors and it says a generous donation by Pfizer Inc. and 3 key opinion leaders, they have no idea. These are the doctors that are doing this. So if that's the forms that they're using, and that is kind of what we've become as like standard. And to your point, we'd like to think that they're getting prescribed by psychiatrists, but the reality is they're coming from a lot of just normal GPs.
I'm going to contradict Kim here and David. Primary care doctors, general practitioners, are better doctors than psychiatrists for the most part. Let me introduce you to 2 words. You think of a psychiatrist like us here, and you think of us as specialists. We bill ourselves as specialists. We're partialists. General practitioners are generalists. They give more drugs, they see more things happening, and they're probably much better placed than psychiatrists generally to recognize when drugs are actually causing a problem or not. One of the other things you need to appreciate, though, is this idea about depression being common. Up till the SSRIs, it wasn't. The first antidepressants were nearly not brought on the market during the 1950s because the companies said there are too few people who are depressed. The nervous problems we had were viewed as anxiety and tension, and we had great treatments for that. We had the benzodiazepines. When the SSRIs come on the market, the problem for companies was to convert cases of anxiety into cases of depression, to convert cases of Valium into cases of Prozac. And a dance began happening. We changed the words we used. We stopped saying I'm nervous or I'm tense. We began saying I'm sad and unhappy. But these are just words. They're not necessarily reflecting a real medical illness. Classic melancholia is a rare disorder.
All right. Is this working?
This one.
This one is. Okay. Thanks, everybody. Great questions, great conversation, lively conversation.
And we can go to 5:30. That's when it's supposed to.
Okay, well, I was gonna give Bill some time to wrap it up, put this all in a box and send us on our way.
More time, question from the audience.
You want to do a few more? Okay, a few more questions.
We'll end by 5:30 no matter what.
So Bill, do you have a sense for how much time you're gonna win? I know, I sense that. Question, especially given the data that's been presented here, was from a student. You know somebody's struggling with depression, perhaps there's somebody, they're being treated pharmaceutically as well. What kind of how do you have a conversation with, what's your conversation with a peer that's struggling with depression, whether or not they've seen somebody yet or they have, and your thoughts about how to treat it are colored by what's happened here today? What's an approach to a friend that you may recommend?
I will go back to the word choice. There's some choices. Science has given us the several options that I tried to outline in my talk, and so that's how I would talk to this friend. You know, it's up to you, but here are some choices, and happy to tell them anything they want to know, answer any question they might have.
It's hard to discard Dr. Haley's comment about you can take the poison from this doctor.
The brainwashing from this therapist.
Okay, so sure, that's not happening.
Well, that's why I emphasize choice.
Okay. Well, one of the key things you need to know is that these conditions, they may be a bit severe when they happen, or you may be a bit sort of out of sorts or whatever, but they only last on average 12 to 16 weeks. When we're talking about informed consent, it's not just about what are the hazards of the pills. It's you've got a condition that's going to clear up anyway, whether we give you a pill or not. In fact, it may clear up quicker without the pill. And one of the options is, for instance, let's try without the pill, and I'm happy to see you weekly, and you can come back to see me. And if things don't clear up, then maybe we can use something like a pill or brainwashing.
Okay, get out of the way.
Go ahead. David, can I ask a question about your talk? First of all, just do you charge per session?
You're asking?
Yeah.
I'm retired, so, but I charged, I think I was working 125 a session, something like that.
125 a session? Okay. So you had a slide dealing with the costs of therapy.
Yes, that was from the division study, yes. Yeah, and that was a follow-up by Dobson, yes.
Yeah. So the issue that I run into in practice is a financial issue about accessing therapy, because there are a couple of issues that we run into. One is access to therapists, because there tends to be a little bit of a wait to get into a therapist. Whereas getting into like medication through their GP, for example, seems so much more accessible. Like a 90-day prescription for Prozac, for example, or Zoloft is $10 at Walmart. So one of the things I was thinking about as you were speaking was how do we lower the cost and increase the access to therapy if in fact your data is holding, right? And I have no reason to doubt it. Not having access to it essentially makes that particular treatment modality useless to some people.
That is a fair question for us. In all of these studies, of course, in the medication condition, patients were seen in most cases weekly. So there was a cost. The standard of care does not involve just giving someone a pill for 90 days and never seeing them, of course. But that often happens, I think, in general practice, and it's a problem. But most of the psychological treatments are limited, usually 12 sessions in that range. And so that's why those guys, Dobson and so forth in that study, thought that after treatment that's time limited, the cost flattens out. And that's how they concluded. Now, in regards to that it was cost effective to offer therapy. Regards to access, that could be a real problem. And fortunately, there are a couple of organizations, for example, someone's interested in pursuing behavior therapy, association called the Association for Behavioral Cognitive Therapy, ABCT, and that will list in an area who specialize in that kind of treatment. So that might be a way to access treatment. But people don't know where to go. You're right. Where am I going to find someone who specializes in that kind of treatment? And that's a challenge.
I have two more criticisms, okay? One is that just like Dr. Healy and you are saying that bad data about psychotropics is suppressed, bad data about bad therapists is suppressed too. Nobody has any idea about what the actual outcomes are for each individual therapist, right? Like I constantly run into this issue with my patients where I have like this narrow group of therapists that I'm reasonably confident in sending my patient to because the outcomes tend to be good. But there is no way for the general public to access which therapists are good and which therapists are not because there's no outcome data on any individual therapist.
That's true. And therapy is without risk. It's low medical risk, but it's not without risk. And so with medication, the way I've framed it is this, is that even if you're getting medication, you still have some of the risks associated with a therapy because you're talking to a provider. So you're getting really all drug treatments in psychiatry are a combined condition of treatment of some kind. Rarely is it just, here's your pill and we don't need to talk, right? So, but of course, but the medical risks associated with therapy are lower. But there are many examples of therapy side effects like false memory syndrome that was precipitated by hypnosis or some other kind of treatment. Therapists sometimes cross ethical lines and don't maintain the boundaries and so forth. But those kinds of risks you can also see in medication treatments offered by a psychiatrist therapist.
The last thing I'll say is considering the demographics of therapists, there are about roughly 200,000 therapists in the country and another 80,000 psychologists in the country. 75% of them are women and 75% of all therapists are white. And so there is a demographic issue here because therapy does really seem to, at least in terms of availability of practitioners, seem to really cater more to white people and women, especially because a lot of times the therapeutic alliance is strongest between clients and therapists who share some sort of background in some way, you know. So.
That's a fair point. We need to develop therapists that are more representative of the population out there. Absolutely agree.
Did you have a question?
Why don't we take one more question?
Okay. This that talks about AI, and I get asked about this a lot by students as well. If somebody goes to their AI therapist and says, "What should I do about this anxiety or this depression?" They're going to get oftentimes a pharmaceutical answer. And you talked about AI propaganda. And just comments about, we're sort of facing into that wave, a big wave.
A quick comment in here.
Yes,
Yeah,
sir.
okay. AI is awfully dangerous. It's total propaganda at the moment. That's generative AI. Whereas supposedly full AI, an AI that can learn, that's still to come our way. Now, let me give you a thought experiment. If full AI is allowed to kill a few people en route, but its randomized control trial pits a group of doctors treating you using the standards of care and the published articles in journals and evidence-based medicine versus a group of doctors who work with you, listen to you and believe you, and where what you're saying contradicts what the evidence base says, who's going to get the best outcomes? And my sense is that full AI is going to opt for relationship-based medicine and not so-called evidence-based medicine. And it can help us even further, which is when you're on 8 or 10 drugs, as increasingly even teenagers are, getting off these things is terribly individual. The drugs that Bill may not be able to get off may be totally different to the ones that I can't get off. It's very individual. There can never be randomized controlled trials that show us what to do. It has to be based on a close relationship. But what AI potentially can do is looking at all of us trying to manage this, trying to reduce the medication burden people have. What it can potentially do is help track paths that may be more successful or less successful. So it might contribute, it won't replace a good relationship, but it may help contribute.
Dr. Healy, do you actually have a suggestion or a plan to promote more relationship-based medicine and psychiatric prescribing rather than RCT-based or database? Like, do you have actually ways that we can encourage this?
I've been talking about it for ages. I've picked the ideas up from the women in my life, Kim and others, who've told me, people who've coined the phrases that seem to me to be most helpful. Lectures from people like me or books 40 years ago might have made a difference. They make no difference now. We need a younger generation who's having to manage the total propaganda situation we're in to find ways to manage it. If you're asking me to find a way to manage it, I'm too old.